Welcome to this series where I'll be discussing the 2026 ACC AHA guideline on the management of dyslipidemia. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in easy endo prep designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.easendoprep.com to enroll in the full course or start your free trial. Today, I will review the guideline recommendations for screening across both pediatric and adult populations. Abnormal lipid levels are very common, affecting roughly 20 to 25% of both adults and children. At the center of this is ApoB, containing lipoproteins, which are a major causal driver of cardiovascular disease. Lipid-lowering therapy reduces that risk. The key driver is duration of exposure to elevated LDL. The longer a patient is exposed to elevated LDL, the higher their lifetime risk of cardiovascular disease. Screening asymptomatic individuals allows detection of both multifactorial dyslipidemia and monogenic disorders such as familial hypercholesterolemia, which may remain clinically silent for decades. Early exposure begins in childhood. Pediatric lipid abnormalities are associated with early vascular changes and increased risk of cardiovascular disease later in life. Childhood lipid levels track into adulthood, and genetic data shows that lifelong lower LDL is associated with lower lifetime cardiovascular risk. Approximately 25% of adults in the United States have an LDL of at least 130 milligrams per deciliter. Heterozygous familial hypercholesterolemia affects about 1 in 250 to 300 individuals. Many adults, particularly younger adults, remain unaware of their lipid levels and are untreated. There are no randomized trials demonstrating benefit or harm of screening younger adults for reduction of cardiovascular events. However, the rationale remains strong. There is a clear causal relationship between ApoB lipoproteins and cardiovascular disease. Effective lipid-lowering therapies reduce morbidity and mortality with greater benefit when initiated earlier. Lipid testing is low cost and broadly acceptable. Universal screening is supported. Screening should begin at age 19. In individuals without known lipid disorders, testing should be repeated every 5 years. Screening frequency should increase with advancing age and in the presence of additional cardiovascular risk factors. Now let's talk about children and adolescents. Lipid abnormalities affect about 20% of adolescents. Around 5% have an LDL of at least 130 milligrams per deciliter. Approximately 1 in 250 children have heterozygous familial hypercholesterolemia. Despite this, only 10 to 20% of children in the United States undergo screening. Family history alone is insufficient. Up to half of children with elevated LDL do not have a known family history of hypercholesterolemia or premature cardiovascular disease. Universal screening has been shown to be feasible and effective in multiple countries. The recommended screening window is between ages 9 and 11 years. Early vascular changes can be detected as early as 8 to 10 years of age. Adolescence is not an optimal time for screening because total cholesterol and LDL levels decrease by 10 to 20% during mid to late puberty, then return to adult levels. Catch-up screening should be performed in those not previously screened. Screening may be performed with a non-fasting lipid panel measuring total cholesterol and high-density lipoprotein cholesterol, allowing calculation of non-high-density lipoprotein cholesterol. A fasting lipid profile can also be used. Triglycerides are included in a fasting lipid profile. ApoB measurement is not part of routine pediatric screening. Familial hypercholesterolemia affects approximately 1 in 250 to 300 individuals and is associated with a 2 to 4-fold increased risk of premature cardiovascular disease. Up to 90% of cases remain undiagnosed. Cascade screening is essential. First and second-degree relatives should be screened, including siblings, children, parents, grandparents, aunts, and uncles. This approach identifies additional affected individuals and those at immediate risk. Genetic testing can be considered in patients with a family history of premature cardiovascular disease, significant primary hypercholesterolemia, or markedly elevated lipid levels. Panel-based testing for pathogenic variants is recommended in appropriate cases. In children with suspected familial hypercholesterolemia, screening can begin as early as age 2. This supports early lifestyle intervention, earlier diagnosis, and earlier management while strengthening family-based screening. The key takeaway is this: screening for dyslipidemia is focused on identifying lifetime cardiovascular risk early. Earlier detection and earlier intervention significantly reduce long-term cardiovascular disease. Let's end with the numbers to remember. At age 19, we start screening adults without known lipid disorders, repeating the screening every 5 years or sooner if risk factors are present. For our pediatric patients, the universal screening window is ages 9 to 11, with the earliest screening starting as young as age 2 in high-risk children, particularly those with familial hypercholesterolemia. This was another bite-sized episode of Endo in a Bite. Remember to visit www.ezendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. Let's get through this document one bite at a time.